Good morning, everyone. We're going to go ahead and get started. Welcome to day 2 of the BKD Billing and Coding Boot Camp. Today and tomorrow, it will be focused on rural health clinic billing and coding. And for those of you who joined us yesterday was the hospital billing and coding. My name is Kate Stenyam, and I'm a program manager for the Delta Region Community Health Systems Development Program. The Delta Regional Authority and the Health Resources Services Administration's Federal Office of Rural Health Policy have partnered together to support the DRCHSD program. And through a cooperative agreement with the Federal Office of Rural Health Policy, the National Rural Health Resource Center, where we are located, administers this program and manages the provision of services to the selected hospitals and communities. I would just like to take a minute to thank you all for joining us today for this exciting educational opportunity. We have an exceptional trainer from BKD today, Marla Dum, that will be leading the training. Through the DRCHSD consultations, many of you have probably already know of BKD and the consultants that have been on site with you. Marla Dum is a managing consultant with that organization, with BKD. A few reminders that before we go ahead and get started, the boot camp is open to participating DRCHSD hospitals and clinics. And following the training, BKD will provide a one-on-one coaching call with each organization that completes the training to resolve specific coding and billing challenges. If you have not already done so, please coordinate this call with your team, as there is one call per organization that is offered. So again, coordinate that with your team within your individual facility, because there is just one coaching call per organization. If you have any questions on this, please contact our program coordinator, Sinava Hackman. I'm now going to turn things over to Sinava, and she is going to go over some housekeeping details before we turn things over to Marla to get started.
Good morning, everyone. My name is Sinava Hackman. As Kate mentioned, I am the program coordinator for the Delta Region Community Health Systems Development Program with the National Rural Health Resource Center. I'd like to welcome you all today to part 2 of the BKD Billing Coding Bootcamp Rural Health Clinic Training. We're glad you could all take the time to be here with us today. Before we get started, I'm going to go over a few housekeeping details. When you call in, your phone line will be muted. To unmute or remute your line, press *2. Once you call in, please keep your computer speakers on mute to avoid any echo or feedback. You can communicate via the chat box at any time, which is located on the left-hand side of the screen. We'll go over any questions at the end of the presentation. The file share box located below the chat box in the lower left corner contains a copy of today's webinar materials. When you click on the name of the file in the file share box, you can then click on the download button to download that file directly to your computer. Throughout the presentation, there will be polling questions that will be asked. The poll questions will be in a gray dialog box with a question. Please answer each question to the best of your knowledge. Today's webinar will be recorded, and a link to the recording will be provided to you when it's uploaded to our website. Now I'd like to turn it over to our speaker, Marla Dum with BKD.
Well, good morning. This is Marla Dum. Sinava, can you let me know whether you can hear me?
Yep, we can hear you.
Okay, wonderful. We had a few technical difficulties this morning, so I just wanted to make sure. Welcome, everyone, to this session this morning, and I'm very pleased to be with you today. I know that some of you may have been on the session with Paula Archer yesterday, and I think that went very well, a lot of great information for the hospital side. Today, we're going to be focusing on rural health clinic. Whether your organization has a provider-based rural health clinic or a freestanding, we should be able to cover both and answer any questions for both throughout the presentation. We also have part 2 tomorrow, so this information has been split into 2 sessions. Today we're going to talk about some of the background of rural health clinic. Sometimes we find that is valuable for those who may be new to RHC or just need a refresher, quite frankly, on where resources are located, what the background of Medicare's intent for the rural program was. Then we're going to move into the requirements for encounters. Who are your core providers? We're going to answer a lot of those questions that you may have about what can we provide during an encounter, what can our RHC provide, how are we supposed to bill for those services, what does not qualify for an encounter, how do we handle that. And then we're going to finish up today's session going through the detailed billing. And that is basically what does our UBO4 need to look like when it goes out to primary Medicare. I will touch briefly on Medicaid requirements if that information is known. We're going to focus mostly on the baseline Medicare requirements. And again, this is for primary Medicare only. And we'll touch on those state Medicaid requirements that we usually see across the country that you may be familiar with in your area. That information, of course, state Medicaid has their own way of doing things, and although they are under this same rural benefit, a number of the state plans will often have specific ways you need to bill to that program. For example, whether it's on a UBO4 or whether it's on a 1500. And they also have some varied reimbursement options for some of the services that primary Medicare does not cover. And some of that we'll cover in more detail in tomorrow's session when we break it down by some of the specific services. So to get started, I wanted to provide you with just a kind of a list of links that would be pertinent to the states that are represented under the Delta region and on our call today. And really we've provided you with regional MAC links as well as HRSA links. And the first link that we provided you is really the CMS Rural Health Clinic web page. They have one specific to Rural Health Clinic. This is basically your guideline going forward for all things Rural Health Clinic. There's two primary manuals that you really do need to have at your at the ready, really, at any time to refer back to, because these are really the two primary manuals that guide us as far as what is eligible and what our billing guidelines are, what our claims processing guidelines are, what's covered, what's not, and that is Claims Processing Manual Chapter 9 and Benefit Policy Manual Chapter 13. So throughout the presentation today and tomorrow, you will see citations that we've pulled from these various manuals. So hopefully those resources will be helpful to you. HRSA, of course, is really another governing body that assists with rural benefits and really provides some resources for the rural side, as well as they're the ones that set the shortage criteria, the HIPSA criteria, the medically underserved area criteria that a rural health clinic has to meet in order to even start that survey process to become a rural health clinic. So that's why I wanted to provide you with the HRSA resource as well. I've also provided you the links to your state associations. That can either be under the National Association of Rural Health Clinics. Sometimes they're under the National Rural Health Association. There's really two governing bodies in the nation who guide the rural health side. And then your individual state associations. Some of those are primary care associations, which may have membership from both RHCs as well as FQHCs, and some are strictly for rural health clinics. A number of these associations also, especially if they are tied to the NRHA, will provide some input to critical access hospitals if you are tied to one of those entities versus a PPS entity. So these are valuable networking colleague associations that we feel it's very important to be involved with. We as an organization are also very involved with some of these organizations and provide training. We are also often asked to provide additional information to these associations and work with them closely when they're deciding what they need to take back to CMS or if there's things that really need to be looked at. We have always prided ourselves that we are one of the consulting firms that they often will reach out to for additional feedback. So we always encourage our rural health clinics to be involved actively in the state associations just because it provides you that really valuable network of colleagues who are dealing with the same rural health clinic issues that you are. Here's just the face pages of those operating manuals that we recommend that you become very familiar with. The Claims Processing Manual, the Benefit Policy Manual, and it looks like I copied the Benefit Policy Manual twice. Whoops, I just now noticed that. Obviously the claims processing. The third manual that I have noted here is the State Operations Manual, Appendix G. This is really the manual that our survey certification processes go through. The state, whether they're working through CMS directly or whether they are members of there's two other associated bodies that CMS has approved to provide survey and certification services, the Triple Quad A, and then there's, I think there's another one. I don't work as much on the certification side, but there's two organizations that CMS has approved to do those surveys and certifications for new RHCs. And really, we go back very frequently to this Appendix G. It has a lot of information about really how an RHC has to be run, the guidelines for integration, for management, for medical directors, for staffing, and other items like that are not necessarily tied to claims processing or billing or coding, but really the actual running of the RHC. So that's another valuable resource that you might want to refer to or put in your library. So a little bit of background. The Medicare program put the rural benefit into place many years ago, back in the 1990s, to not only encourage the increase of primary care within the rural communities, but also to increase the use of non-physician practitioners. That was one of the goals that the Medicare program had, since they did fully realize that it was difficult to get physicians into some of these rural areas. And so to offset that staffing, they wanted to make sure that they opened up the door for the availability of non-physician practitioners. So that's why in the rural setting for your rural health clinics, there's not really a payment difference. We have that one single payment that you receive for those face-to-face services, and that's partly why Medicare and state Medicaid went to that payment methodology, so that option to really expand your staff, fully utilize non-physician practitioners, as well as fully provide primary care services in the rural setting. That's part of the reason why they had that benefit. Also, they wanted to make sure that services provided in a rural health clinic are medically necessary. These guidelines on the slide are the general Medicare criteria that they impose to any site of service for medical necessity. The service must be needed for the diagnosis or treatment of the beneficiary's medical condition, the direct care and treatment of that beneficiary. They must meet standards of good medical care, and the service is not mainly for the convenience of the beneficiary, provider, or supplier. That's just the general CMS rules. One thing you want to keep in mind in a rural health clinic setting is that Medicare pays very close attention to medical necessity. Why do they do that? Why would they be worried about that? Well, any payer is concerned that when they're paying you for a professional service, that there was a true reason why that patient needed to come into the clinic, walk through the door, and be in a waiting room to see a physician or a non-physician practitioner. There needs to be complaints or a reason to come back and see for a condition, whether it's worsening, whether it's a new problem, or whether it's just a routine follow-up for perhaps a heart patient or hypertension or diabetes where it is their 6-month check. They may be asymptomatic when they walk through the door, but the reason for the visit is because that clinical professional needs to assess that condition to determine if that patient is doing well on meds, do we need change dosage, etc. The reason RHCs are looked at very closely for this is because of how you're reimbursed. And we'll go into the reimbursement in detail as we go through the presentation today. But you are basically paid a flat rate each time a patient walks through the door and enters an exam room. So because of that, Medicare wants to be very sure, as well as state Medicaid, that there is a good reason for that patient to be in the room. RHCs are audited quite frequently, not only by the Medicare program, but really actively by Medicaid, to make sure that the services that are being rendered and submitted on the claim form and paid under the encounter rate are medically necessary. An example, we worked with a very small rural health clinic several years ago. This was in Texas, and this provider was a one physician, one nurse practitioner practice. The physician had been in business for a very long time and had been a rural health clinic for a very long time. and Medicare imposed an audit on them just due to volume. They went back and asked us to come in. This was an attorney project. They'd already paid back some money to the program, but we were called in to really look to see if medical necessity was supported for these visits. We also were looking at Medicaid cases to see if medical necessity was there, as well as whether documentation criteria was met under the Medicaid program for things like well-child checks, for example. What we found was that this physician had a very consistent note. It was about an inch in length, and it basically said, Mrs. Smith is here today, Mrs. Smith is doing well, had a usual and customary exam of heart, lungs, and abdomen, vital signs, and then the final assessment was, come back and see me in 2 weeks. Every single note was very similar to that. Every once in a while, that patient would actually have a presenting condition, but usually the physician just wanted them to come back every 2 weeks. And why was that? In good part because he knew every time a patient was in the room, he would get paid. So obviously a huge amount of money was paid back, and unfortunately closed out that clinic because of the amount they had to pay back. So just a word to the wise. I know when we educate for providers, physicians and non-physician practitioners and behavioral health side, we always reinforce the fact that Medicare wants every service bill to meet medical necessity, so that patient has a documented sign, symptom, or complaint as to why that clinical professional needs to see them. Now, Medicare does prohibit payments. It's called a statutory lack of coverage or statutory non-coverage for some services, even though they are provided in the rural health clinic. And some of those examples are a routine annual physical. Now, that is not the same as an annual wellness visit, which you all may be very familiar with, or the Welcome to Medicare physical, that IPPE that we're also familiar with. And we'll talk about those two subjects in tomorrow's section, but just wanted you to be aware that there are some occasions where Medicare is not going to pay for a service regardless of where provided and makes that patient responsibility. We also will talk a little bit about diagnostic services and the fact that you do have to pay attention to policies, similar as you did in the fee-for-service world, where a particular lab test or procedure may have a local coverage determination under Medicare. That still applies even though the service is done within the RHC. So let's drill down into some categories. You know, what is covered in RHC? And, you know, we're all familiar with the fact that it's basically like throwing darts at a dartboard when we're trying to figure out what is covered by Medicare. Do we have a clear understanding of how we need to establish our clinic and what's done within the clinic? Just some additional background on the benefits. Your patients are eligible to receive those RHC services under Part B. And when I say that, that means that the payment is generated out of the Part B bucket, but you are filing your claims to Part A. So it's a little bit confusing because Part B we usually think of as a fee-for-service model, which is true, but this is basically a payment for primary care professional services, but paid under the Part B bucket, all those sent through Part A. Your payment methodology is what's considered an all-inclusive rate. In other words, it's in some ways a cost-based scenario where every year your rural health clinic has a cost report that's submitted. They take into account the productivity, the cost that goes into doing business, the cost that was incurred to do those services over the year, and they come up to an average. The all-inclusive rate, the base rate, is always set by Medicare once a year, and then depending on whether you are a freestanding RHC or a provider-based RHC, that will determine the amount that you will receive for the remaining year for each of your face-to-face encounters. If you are tied to a critical access hospital with beds under 50, there is cost adjustment for that type of a setting. And so your base rate may be raised or adjusted based on the cost. There are other circumstances where your cost report helps to assess what that encounter rate is going to be every year. So your services, your professional services, or those that are performed during your face-to-face encounter, are listed on the UB04 claim and sent to Medicare Part A. Medicare pays you 80% of that all-inclusive rate, and then the patient is responsible for the co-insurance. And for a rural health clinic, the co-insurance is 20% of the charges, of the total charges, including their deductible that they are due to Medicare each year. Now, those of you on the billing side, you do want to make sure you have that clear, that it's 20% of charges, because on the Part B side, when you were just paid fee schedule for services, or would be paid fee schedule for services, such as if your providers go into the hospital setting and you're sending those services out on a 1500 and being paid fee schedule, that coinsurance is based on the allowance. So that's something that differs the RHC from a regular Part B environment. You are assessing a coinsurance of 20% of total charges. This is also why we really encourage you to make sure that you are appropriately capturing charges. If the physician does an evaluation and management service, then there is a procedure done that day, and they order a blood draw, they order a drug administration, making sure that all of those charges are listed on that UB04, because those total charges is what's going to drive your coinsurance. Now, Medicare will not incur a coinsurance or deductible for services that they have listed as a covered preventive service. So this would be like your IPPEs and your annual wellness visits. There are many other covered preventive services that are listed on the Medicare site that are eligible for performance in the RHC setting that are not going to be eligible for that coinsurance or deductible assessment. So those are some of the perks for our Medicare beneficiaries. So again, you are going to be paid an all-inclusive rate. I will also refer to that as an encounter rate throughout the presentation, or you will see the acronym AIR. So those are all one and the same thing. For 2019, the payment limit, or the baseline, is $84.70. And again, for a hospital provider-based RHC, if you have 50 beds or less, then that cap is adjusted based on your cost report. You may be in some areas also where your cost report causes the cap to be adjusted based on that cost, but in those circumstances we see that with a provider-based situation. So let's go through some of the basic rules of RHG just as a refresher for you. Medicare and Medicaid considers billable providers as core providers. The services that they render that are eligible for billing and payment under the encounter rate are considered core services. So we want to note who is actually a core provider in the RHC. We will see physicians, those will be your MDs and your DOs, and any professional services that they perform hands-on or face-to-face. That includes anything within the clinic setting. That might be an in-office procedure like lesion removal or a joint injection. That might be preventive services that are covered or performed by those individuals. Anything that's occurring during that face-to-face encounter is considered a core service. You also have your nurse practitioners, your physician assistants, and your midwives. Then also clinical psychologists and clinical social workers. And tomorrow we will touch a bit on the behavioral health side because there's always questions on that. So be prepared if you do in fact have behavioral health services in your organization. We will touch on the criteria under Medicare for what level of education these individuals have to have as well as licensure, and then who is not allowed under Medicare versus perhaps state Medicaid, for example, or your commercial side. Now, the clinical psychologists and clinical social workers, obviously those will be doing behavioral health services, mental health services, as well as psychiatrists, which would be under the physician category. Now, going back to this, you will note that there is no listing for staff, no nurses, no technicians, no ancillary staff. That is because they don't consider a visit or service by ancillary staff to be a core service unless those services have been provided as part of that encounter. And we will walk through that in great detail here over the next few slides. So keep that in mind as we talk through this. The core services that are eligible for billing and reimbursement are professional, meaning that is going to be a face-to-face, hands-on service provided by one of those core professionals. There are some preventive services that are also covered under the benefits. So we have like the annual wellness visits, the IPPEs, things like smoking cessation, some of those other preventive services that Medicare has listed as eligible in the primary side. So there really are 4 categories that you want to think about when you're looking at what is going on within your RHC and how are we billing and how will we be paid for those services. The first one is what's defined as the encounter. This is going to be your face-to-face visits. This will always be with a core provider, either a physician or a non-physician practitioner, social worker, psychologist, nurse, midwife. Those are your core providers. Those services that they perform during that encounter are reported on the UDO4, and they are paid under the encounter rate. You have another category that we consider Incident 2, and you may be familiar with that term, Incident 2. That means that a service in this scenario has been provided by ancillary staff, nursing, your RNs, your LPNs, your MAs, maybe you have a technician on site, whoever is considered to be an ancillary or auxiliary staff, and they are providing services under the order or under the treatment plan of the treating physician or non-physician practitioner. Now, these services can be provided usually in 2 scenarios. One is that the physician is already in the room with the patient. They've already evaluated them and assessed, known that the patient is found to have pneumonia. They order the nurse to come in and give the patient an injection. So those services that the nurse does when he or she walks into the room, administers the injection, are considered Incident 2 services and billable on the same claim because they were performed during that visit. So your claim form, your UDO4, or the claim form that's appropriate for your state Medicaid plan would have not only the physician's work, an evaluation and management service most usually, and then you would have the drug code and the administration code. A lot of practices forget to put the administration code, but you want both parts of that service to make sure you've got all of your charges captured. They may have also ordered lab work.
Marla, are you there?
That it would be an imaging service for that day. Yes? Oh, I thought
I think you cut out a little bit, but you're good.
Oh, okay. You can still hear me?
Yep, you're good now.
Okay, thank you. So the Incident 2 service that's provided during that encounter, you want all of the charges listed on your UDO4 or the appropriate claim form for state Medicaid, and that total service will be paid under the encounter rate. If that ancillary staff is the only person who sees that patient on a date of service, for example, let's say that patient did have an upper respiratory infection, and maybe they've given them Rocephin, and they give that during that first encounter with that provider, then they order the patient back in a couple of weeks maybe to get a booster of the Rocephin. When they come back to see the nurse on that next visit, that's considered to be a nurse-only service. That's what we refer to those as. It's a nurse-only service. They don't see the physician or a non-physician practitioner. In this circumstance, there's no reason to. They just come in, get their injection, and leave. Those services are not billed on a claim, and that's going to be to either state Medicaid or primary Medicare. Those services are tracked in your system and usually adjusted off so that it does not drop to a claim. And these are some of the types of services, supplies, nursing time, things that your cost report preparers are looking at for reporting in the cost report at the end of the year. Okay, so those services are not paid under the encounter rate, but they are included in costs at the end of the year. Now, we have a category called non-RHC, and I do want to provide you a definition of non-RHC because there's a number of clinics that we work with that misinterpret this definition, and sometimes that can lead to some commingling violations because services start to be separated out to different rooms and down the hall and on different days in order to get different payment for these services that providers or the administration may think cannot be performed in the RHC, or they are going to be paid under encounter rate and they may want a different type of reimbursement. That's a cautionary word to maybe not do that because Medicare would frown on that. Non-RHC just basically means it's a service that can be provided in your RHC setting. It's a usual and customary procedure like lesion removals, joint injections, anything that your providers would normally do in the course of business, regardless of payer, but it's not paid under the encounter rate. It may be paid under the physician fee schedule. So we're looking at services like technical services, like our imaging or our lab tests, or if your providers are going to another setting such as a hospital, those services are paid under fee schedule. They are not part of the clinic benefits and therefore not paid under the encounter rate. So it just means that there are services that can be provided in the RHC or provided by your professional staff. They just may not be paid under the encounter rate. Okay? Now, in some of your circumstances with your PPS hospitals, that means that some of those situations, those technical services might be paid under PPS or an APC model for an outpatient service. They might be paid under a cost-based if you're tied to a critical access hospital and it's a lab service. It might be paid under fee schedule if it's a diagnostic test. So that's what non-RHC means. It just means it's not paid under the RHC encounter rate. And then finally, non-covered services. We usually refer to these as statutorily non-covered under the Medicare program. They're not paid under the encounter rate. They would also not be paid under Part B. They are patient responsibility. They are things like our routine annual physicals, where the patients come in once a year for that tune-up. Let's look at everything, head to toe, that annual physical, well child checks, for example, well woman exams, things like that that we refer to as a routine annual physical. Those are patient responsibility. And that's for primary Medicare. When we talk about state Medicaid, obviously our EPSDTs or our well child checks are covered, our routine annual physicals are covered. That's one of the differences between primary Medicare and state Medicaid. So let's drill down into some of these categories in a little bit more detail. First, we're going to talk about the encounter. Again, these are with your core provider. They are face-to-face, hands-on. The payment is made for that professional service to include any of the services that your nursing staff may do as part of that encounter. Now, the all-inclusive rate for our encounters does not include payment for things that are outside of that, such as your lab work, any imaging, any EKG tracing, and again, this is going to be diagnostic testing that you are doing within the four walls of your RHC. Also, hospital professional services are not paid under the encounter rate. That's outside of a clinic encounter. So the definition is a face-to-face, and I really want to emphasize this face-to-face one-on-one with a core provider because we've talked about the fact that nurse-only services are not considered an encounter. So you want to think, what is your RHC doing? Are there circumstances where you might have a patient come in for an annual wellness visit and you schedule that with the nurse? Blood draws that are done just by nursing, drug administration or vaccine administration, blood pressure checks, all of those things are not going to be eligible for encounters when performed solely by a nurse. And we'll touch base on those annual wellness visit risk areas during our session tomorrow. It must be a medically necessary medical or mental health visit. Medicare separates those two. You have medical care and you have mental health care. You may have multiple medical visits in one day. For example, you may have a female who goes to family practice at 9 o'clock and then has an appointment at 10 o'clock with her OB-GYN within the same RHC. Those are two medical visits, and we'll talk about how that impacts reimbursement. If they also had an appointment with a therapist or a social worker for their therapy visit the same day, you would have a separate encounter paid mental health visit because those are considered two separate niches within the benefit for primary Medicare and state Medicaid. There is also coverage for the transitional care management, which we'll talk about tomorrow, as well as advanced care planning visits. Those are some of the services that Medicare has parsed out over time and allowed for billing as well as payment. Some of those payment methodologies are a little bit different, and so we wanted to discuss those separately tomorrow. So your RHC encounters provided by your employed or contracted staff may occur in these settings: in the RHC itself, within the four walls, a patient's home. So does your physician or your non-physician practitioner go into the home to see the patient? Nursing facility. This is a big one. If you have providers that are seeing patients in a skilled nursing facility, a swing bed, just a regular non-skilled nursing facility, also other settings such as domicile care, nursing homes versus facility, assisted living, any other kind of residential care facility that would not be behavioral health in nature, those are all visits that are considered RHC encounters and then are driven by the CPT code that you bill and the revenue code that you assign on that UB04. Also, if your providers go outside of the clinic to something that would still be considered that primary care visit, which would be, maybe they're called to a scene of an accident. The big one that we've seen a rise in is school clinics, whether the RHC sets up a specific RHC in the school or whether they are just staffed by the school to staff their clinic. Those are also scenarios that would be considered RHC encounters, and then there would be a specific revenue code that would be used. There's an other revenue code that could be assigned for that site of service. But all of those settings are eligible for face-to-face environments, and they are eligible for, and my slides are not advancing.
We have one poll question I'm going to pull up for everyone. Yeah. If everyone would please take a vote for the poll question to the best of your knowledge. A few more seconds and I'm going to switch back to the PowerPoint. All right, back to you, Marla.
Great. Well, based on the findings, most of you on the line today had the answer correct. Hospital would have been the correct answer to that polling question because that is one site of service that is considered outside of the RHC and paid under fee schedule. So you would be billing 1,500 claims for your providers when they're in the hospital, whether they're in the emergency department, in an observation setting, whether they're seeing patients on the inpatient side. A few of you had marked skilled nursing facility, and remember that that nursing facility setting is considered an RHC encounter because that's where the patient is basically housed. That's their home setting, for lack of a better word. Once they get into the nursing facility, that's where they are housed. That's really where they live, for lack of a better word. And that primary care benefit includes those services to patients that are basically either coming into the clinic or in some type of a home setting outside of those things like school clinics, which would be just considered another clinic setting. So well done, well done. We wanted to define the single visit, or what is our face-to-face encounter and how is that reimbursed. So when you're paying,
Marla, are you there?
more providers, and that's particularly important if your providers or your patients are seeing more than one medical provider per day, and that falls into that category of multiple encounters with the same healthcare provider or supplier. So you want to keep that in mind, that your patient may be scheduled to see numerous providers within your RHC on the same date of service, but if they are all medical visits, then they will be paid one encounter rate. If they see one doctor on the date of service, they're paid one encounter rate. If they're seeing one behavioral health provider that day, they get one encounter rate. So that's why it's important to make sure you're capturing charges correctly, because that UBO4 will need to include all of the charges that that patient incurs on that date of service. So if they do go to a family practice provider at 9 o'clock and then to an OB at 10 o'clock, all of those charges are submitted on one UBO4, and we'll talk later in the presentation about how you list those services on your UB as well as modify them to indicate to Medicaid or to Medicare which ones are eligible for payment on that day. So it's really a one encounter rate per day methodology, although of course there are some exceptions, and these are the exceptions which are applicable to either primary Medicare or state Medicaid. If there is a scenario where your patient comes in and then leaves the clinic and has to return for another visit that was not previously scheduled, for example, they come in the morning with a cold or an upper respiratory infection, but then they leave, and then for whatever reason they have an accident in the afternoon. Let's say they may trip on their front porch and sprain their ankle and they come back. That is an example of two separate and distinct medical visits, and they were not both scheduled on the same day of service. It's an exception to the rule. That would be a scenario where both of those visits would be on the UBO4, and then the case would be modified to show we need payment for that second scenario because it fell into an exception. The second one is when the patients have a medical visit and a mental health, behavioral health visit on the same day. I spoke before about the fact that Medicare and Medicaid both consider all of medical to be in one niche and mental behavioral health to be in a second niche that are separately payable. So the example I gave before about maybe a family practice appointment in the morning and then they come back for a scheduled therapy visit on that same day, both of those services will go on the same UBO4, but you will modify that behavioral health visit to say this is our second eligible visit and we'll be paid 2 encounter rates for that day. The third scenario is a welcome to Medicare physical, or that IPPE. If that is provided, if those services are provided in addition to a medical visit, let's say either a true medical visit for a sign or symptom, or perhaps they did have their routine annual physical that day, that would be a scenario where you would be, particularly for the medical, preventive of course would kick to patient responsibility. That was not a good example. But the medical visit, let's say they came in for their routine hypertension check and it was time to do their welcome to Medicare physical because they had just rolled to Medicare coverage, They did that work as well, filled out all of that paperwork. They could modify that on the claim form, and Medicare should pay you an encounter rate for the IPPE and an encounter rate for the medical visit. The same would be true if you had a mental health visit on that day, like a therapy visit. And then they also saw the provider for their IPPE. Those two visits would be paid separate encounter rates, so those are your exceptions. We also want to remind that not every scheduled visit with a provider may be reimbursable. We do have scenarios that Medicare and state Medicaid, really any payer, watches very closely. It falls again to medical necessity. Why are those patients coming in? Why have they scheduled? For example, Medicare does not consider a visit for med refills or to discuss lab tests or to do anything with medications if you're just filling out a prescription to be a reason to have a patient in the room. They don't consider those to be medically necessary. And so there's always two scenarios with that. And that's what we discuss with our professional staff when we do education. If your patient has come in for diagnostic testing and everything's normal and there's nothing that's going to occur or need to be done to change treatment, then there may not be a reason to have that patient come in to say your lab tests were normal. I know I get a letter or a phone call from my physician to say everything looked good, we'll see you in 6 months. I don't go in. Now, if that patient has results that does impact decision making, and now the provider wants to have that patient come in to not only be reevaluated, but maybe discuss changes in treatment. You know, we need to change this drug out, it's not working, or we need to increase the dosage or remove that medication. Maybe there is a surgical option now that needs to be considered based on the findings, maybe an imaging. Those are medically necessary reasons to see the patient. That's why we really encourage the providers to be clear on their chief complaint about why that patient is coming in. The same thing holds true for med refills. If it's a scenario where the pharmacy has contacted the patient to say their refills have run out and they need to contact their provider, usually the pharmacy takes care of that. They usually contact the provider sends a new electronic prescription, and there are only circumstances where the patient has to come in for a refill, literally, is if it's a time for the patient to be assessed or evaluated to see if that medication is still appropriate. Those are medically necessary visits. There also may be that sign or symptom issue, or it's a standard of care for a particular type of medication that patient be seen frequently, or the frequency that they need to be seen to be evaluated based on how that medication is doing for that patient. That would also be medically necessary. But you do want to take note, but if you have any providers that just schedule patients every time they have diagnostic tests, whether they're normal or not, because that is an area of risk for rural health clinics. Also, the interpretation of results. When your providers, your physicians or non-physician practitioners may be reading, let's say, an EKG or an imaging, they themselves are doing the reading, and they may not have done that on the date of service when the patient was there. That solo service, when it's done days later, is not eligible for billing. A separate claim form for that. That's not a face-to-face service. If they've performed that interpretation on the same day, you know, in most circumstances, an EKG is usually read when the patient's there, and then the results are used to manage that patient. Then that EKG interpretation charge is added or listed on that UD with their office visit. But otherwise, if they perform that days later, or if they have services come in for Medicare or state Medicaid primary patients, maybe imaging or something comes over from the hospital that those RHC providers are read. That's a different scenario, because if that patient is in the hospital setting, sending over imaging or any other diagnostic testing to be interpreted by your providers, that is now an out of the RHC service because that patient's in the hospital. So that would actually be a scenario where you'd submit a 1500 claim for that interpretation in that scenario because the patient is actually housed in the hospital. So it would be considered a hospital service, although the patient or the imaging is read in the physician's office. So those are some scenarios you want to keep in mind too. A solo interpretation provided by a physician or non-physician practitioner that they may do in the office and follow up to a visit in the office, but they do it several days later, that is not going to go out on a claim form. It's going to be considered kind of the cost of doing business, unfortunately, because we're not able to roll that charge onto another claim form similar to what you might be able to do with some of the ancillary services that might be performed within 30 days. We're not allowed to roll those professional charges, only ancillary charges. And when the patient is followed up with the registered nurse per the physician's order, we've talked about those nurse-only visits. Those are not eligible for billing on a UDO. For that, obviously coded, charges are assigned, but then backed off so it doesn't drop to a claim. And we did talk about med refills. Refills listed in their scenarios of what they would not consider to be an eligible face-to-face encounter. So if there's a reason for your providers to see them, there is a reason for them to face-to-face hands-on evaluate them as a result or in the need of dosage changes for those medication refills, that would need to be very clear in the documentation. Here is just another slide as a reminder on any diagnostic interpretation, particularly when performed not as part of that encounter. Okay, now we're going to talk about Incident 2 services, which are those done by your ancillary staff. Here is the information out of the Benefit Policy Manual, which in short just says that your nursing facility may do services under the order of a physician or a non-physician practitioner. And those may not meet the qualification of a face-to-face core provider visit, but there are services that they do under the order of the treating provider. Things like blood pressure checks, allergy injections, prescriptions, basically nursing services. Those are what fall under a definition of Incident 2. So the cost of those services that are done in the RHC are part of what is looked at the cost report, and then it also says, but the provision of these services does not generate a billable visit. Incident 2 services provided on a different day as the billable visit may be included in the charges for the visit if furnished in a medically appropriate time frame. So we'll talk about that in a slide or two here, the 30-day rule. So the Incident 2, you're going to be looking to those services done by your ancillary staff. Remember that direct supervision must be met. That means that if your nursing personnel are doing services in the clinic, and this is really regardless of payer, if your ancillary staff are doing services, they have to be provided under direct supervision, unless it's a service that in their manuals they don't require supervision. So injections, blood pressure checks, anything those nurses are doing outside of a face-to-face encounter have to be done under direct supervision, which means there has to be a physician or a non-physician practitioner in the four walls of the RHC. Doesn't mean they have to be in the room, they don't have to be at the nurse's station, they have to be in the RHC. Cannot be over at the clinic or another clinic in your system, they can't be at the hospital, they can't be at the golf course. They have to be in the clinic. This is also a requirement under survey and certification as an RHC. You have to have a core provider in the RHC the entirety of your scheduled hours. So if you are open from 9 to 5 and you have scheduled a lab draw hour from 9 to 10 and you don't have patients seen by the providers until 10, and so you don't have a physician come in until 10, then you may be in violation of the RHC rules to begin with. And those nursing services are being provided without direction or supervision. So that puts those charges at risk, really regardless of payer. But particularly for Medicare, you do need to remember, as an RHC itself, you have to have either a physician, a non-physician practitioner, a clinical social worker, a psychologist. You also want to remember that it has to be someone who can supervise medical services. So there are some scenarios where CMS will say social workers and psychologists don't really meet that. It has to be that criteria. It has to be a physician or a non-physician practitioner. So PA, nurse practitioner, to be on site to supervise those medical services. Nurses may provide things like injections, blood draws, of course. They are tied to a visit. Most of our services by nurses do need to be ordered, and the supervising physician does not necessarily need to be the treating or the ordering physician or non-physician practitioner. It's just whoever's in the building. Medicare clarified that in the final rule 2 years ago, just to be sure that everyone understands that you don't just automatically drop the bill under who is ordering it or treating, but who is in the building at the time of that service. That's who goes out on the claim form as your rendering provider on your UBO4. There is a 30-day rule. You know, the guidance under the benefit policy says if it's provided outside of a billable encounter, then if it's within an applicable time frame, you can add those charges onto another visit UBO4, and that's the 30-day rule. So let's say the patient comes in for that upper respiratory infection and has that Rocephin shot. So we have our initial UBO4 with the office visit and the first Rocephin injection, the drug quote, and the administration. You would need to hold on to that claim if that patient had been ordered to come back in another 2 to 4 weeks to get their other injection. If that other injection is administered within 30 days from the date of service of that face-to-face visit, you can hold the claim and then add those drug charges onto that first claim. The UBO4 will go through with the date of service of the face-to-face visit. You also don't want to put a to and from date onto the UBO4, like some of you on the hospital side are familiar with, that you have to do on the hospital side. We don't have a to and from date on the UBO4 or a date range. We have just the date of service of that face-to-face visit. That is 30 days before or 30 days after that ancillary service has been provided. So you want to keep that in mind. We have just a very small, probably a handful of clinics that we work with across the country who have been able to make this work. It's kind of a practice management nightmare because with the electronic systems, it's very difficult to hold a claim without opening it back up and generating a claim. Basically, the doctors just can't sign off, or the non-physician practitioner just can't sign off on their note. They have to hold it. And really the only circumstances are if you've been able to know, or you know that that patient's coming back in within the 30 days. We've had some that have tried to do that with B12 shots or allergy shots that are medically necessary, that they do come in frequently. Sometimes they'll try to roll some of those onto a visit. The benefit really of making sure you add those charges, or if you have the ability to track that and add those charges, is that then you have some more dollars on that total charge line that you can assess co-insurance on. Otherwise, these will all be considered nurse-only services. They will not go out on a claim form, and then they will be tracked for that cost report at the end of the year. Okay. Blood draws. I wanted to speak to blood draws. This has been a large area of confusion over the many years because probably, let's see, 2013 they changed the guideline. So prior to 2013, regional MACs could make up their mind how they wanted blood draws to be billed. Some considered it a professional service and wanted it to go out on the encounter. Others kept it as part of the lab service and wanted that billed out with a laboratory service, so paid under fee schedule, or if a parent hospital was billing that service, it would be paid under that methodology. So there was just too many different varied ways of billing, and Medicare finally put their foot down and said, okay, our determination for the RHD setting, whether freestanding or provider-based, is that a blood draw is a professional service. And so it will depend on when that nurse draws that blood or when that technician draws the blood, whether it is drawn as part of that face-to-face encounter or whether it is drawn as a nurse-only service when the patient just comes in for lab work. So again, if it is part of the encounter, add that blood draw charge, usually that 36415, onto the UBO4. If the patient just comes back in to see the nurse for lab draw, then that service is considered nurse-only. This is one of those services that you can watch to see whether you can roll that based on that 50 or that 30-day rule. But if it's completely out of a 30-day window, then that will just go to cost. Okay. Now, those of you on the phone who are hospital and you have a provider-based RHC, you don't want to generate a blood draw charge when you generate the charge for the lab that was tested or resulted within the four walls of the RHC. We'll talk about that a little bit more in detail when we talk about splitting up diagnostic testing services. But basically, for a provider-based RHC, the parent hospital actually generates the claims for the diagnostic technical component of services done within the four walls of the RHC, like the lab tests, imaging, X-ray tracing, or EKG tracing, excuse me. So in this circumstance, we have had some hospitals that have really had to look at their CDM because that 36415 or that lab draw may be automatically pulled onto the hospital's charge when they generate that outpatient UB. You want to make sure that's not happening when you're generating a charge that's really tied to the rural health clinic because the rural health clinic has to build out that blood draw. It cannot go out on a Part B claim for a provider-based clinic, and the hospital cannot generate a charge and be paid for that. So just wanted to be clear on that. In the independent or your freestanding RHCs on the call, that blood draw will never be billed to Part B for primary Medicare. Okay. Now the rules for state Medicaid are very similar, where that blood draw needs to be part of your professional charge, and if it's done just by the nurse, a claim is not generated. That's part of the Medicaid guidelines as well. Diabetes education, we want to touch on that. Diabetic education in the rural health clinic in itself is not eligible for billing or payment under the encounter rate. For whatever reason, they have not excluded it. An RHC can be an eligible site, and you can have qualified individuals who give diabetic education, but they are not going to pay you an encounter rate for those sole diabetic education or medical nutrition therapy visits in the RHC setting. The FQHC side that we work with, for whatever reason, Medicare has added that to their covered services, but not the RHC. So if you have a scenario in your environment that you are giving or you are doing diabetic education, and this is true diabetic education where those patients are on an education schedule, they come in frequently for their individual or group training, there are some other criteria that do need to be met in order to bill at all or consider those charges towards cost. And part of those regulations are that you need to have your site accredited. So your RHC, whether you have it at one RHC or many RHCs within your system, each of those individual sites have to be accredited, either with the American Diabetic Association or there's an association of medical nutrition providers. There's another organized body that CMS has approved to also accredit. So you have to receive that, and you have to make sure whoever is providing that diabetic education is qualified. So for example, a licensed registered dietitian, if you have nurses doing that, do they have the education in order to give diabetic education? All of those criteria have to be met before you can even consider that for cost. And that's basically what happens. There's no group therapy within an RHC setting, so you would only be able to account for the individual diabetic education visits with the patients, and then again that's going to go to cost because they don't consider that billable. Now, the exception to that is if you would have a scenario where the patient may have had another visit on the same day with the provider, maybe for some other medical condition, and they're also scheduled for their diabetic education meeting that day, you would add the charge to the claim, but you're just going to be paid under the one encounter rate. They're going to consider that an incident to service on that date. In most circumstances, those are usually completely separately scheduled visits with the diabetic educator, so just keep that in mind. Our third category is non-RHC services. And again, we talked about that these are services that are just basically not paid under the encounter rate. They may be services you provide in your RHC, or they may be services that your providers render outside of this RHC benefit, and those are then paid differently. So these will either be paid under Part B for independent RHC, particularly for diagnostic tests, or for our diagnostic test, they will be paid under the appropriate reimbursement methodology of the parent hospital for a provider-based rural health clinic. So let's step through just a few of these that are very common in the RHC setting. Obviously, our imaging or EKGs, that technical component will either be billed to Part B for freestanding, or the parent hospital has to bill that technical component. And we'll walk through those claims here in just a little bit. Hospital services, remember those are completely outside of the RHC benefit, so regardless of payer, if your providers are going over to the hospital, all of those services are $1,500 billing, fee schedule paid. Okay. Lab services, that's going to include the waived tests that the RHCs are required to provide. So if you have a urine dipstick, but then you order and have a blood draw done for another lab test that may need to be done also that's a more invasive or a more complex laboratory test, as maybe say a CBC is done within the four walls of the RHC, that service is technical. So those lab services will be billed to either Part B for freestanding or by the parent hospital on their outpatient UV for lab. But that does include those 6 waived tests. We do get a question on that quite frequently. The other things that we see are things like durable medical equipment. If you're dispensing crutches or you're dispensing equipment that is true DME, the RHC itself has to have a durable medical equipment provider number through MEDICARE. So you have to have that number before you can submit a claim to Part B for payment of that durable medical equipment. Hospice, we want to talk about that a little bit. The RHC itself cannot be a hospice provider. If any of your physicians are noted as a patient's hospice director or provider, they can provide services for the condition of the hospice patient, but not during RHC hours. And those services have to be billed to the hospice, not to MEDICARE. But the providers cannot do hospice-related services during RHC hours. They are not considered, that's double dipping into benefits. If the providers are seeing patients for things that are not related to the hospice condition, then that's fine, and they just send through their usual encounters for those services. But if you have those scenarios, you might want to make a note to take a look and see what's happening with those. Lab tests, we've talked about that already, but these are the 6 wave tests that are required to be done in the RHC. Your RHC literally has to be able to perform all 6 of these in order to meet your certification as an RHC. Now, there are circumstances where, especially if you're tied to a hospital, a lot of times the patients are just sent over to the lab or to the hospital lab to get these tests done, and that's fine as long as you still can show you can do the tests in the RHC. The guidelines do allow you to arrange for services to be performed if not able to do that in the RHC. But your RHC has to be able to perform them. So the equipment has to be there. You have to have staff that are able to do that testing in order to meet criteria. And again, if these are performed like a UA, that is not going to be part of your encounter rate. You want to build that out separately for fee schedule. Here is some more information about how these technical services are submitted, and I did separate them between independent and provider-based because the rulings are different. So in your independent RHC sites on the call today, any of your technical services are billed on Part D on the 1500. You're using your RHC group number, your NPI, and the testing is paid under fee schedule. You want to make sure that in your fee schedule that you have split out some of those charges. You know, if you're doing imaging, that you have a technical TC charge and the professional charge and the global charge, because you're going to have the global charge billed out to all of your commercial managed care plans if you're doing all of the services inside the four walls. Same thing with EKG. You want to make sure that you have the 93005 set up, the 93010, and the 93000 set up for the technical, professional, and global. Now, if you have a provider-based RHC on the call today, whoever is your parent hospital, they have to submit the claim for any of the technical services that you're doing inside the RHC. So that parent hospital will generate a UB04 and you will be paid under the, and billed under the hospital's group provider number, not the RHC's, the hospital's number, and then they file that to Part A and are paid under the applicable payment methodology, whether it's critical access, fee schedule costs, bundled under an APC, whatever the appropriate payment methodology is. Now, we often get a lot of questions about the 3-day window. RHC services are not applicable to the 3-day window, and that includes services that are performed within the RHC, which would be the technical services. Even though you're billing them on the PPS side, it is not applicable to the 3-day window if it's performed within the RHC. And that is present in the benefit policy manual. Just want to be clear on that. We get a lot of questions on that. Non-covered and excluded is our last category. And these are statutorily non-covered. Medicare says in no way, shape, or form are we ever going to pay for these, and the patient is responsible. So these are also going to include any services that are not tied to medical necessity, signs, symptoms, a patient-requested service where there is no condition, signs, or symptoms being treated, but the patient just wants the service. That is patient responsibility. B12 is an example. B12 can be medically necessary if you have documentation of anemia or B12 deficiency, and I will say that Medicare watches those very carefully because those are the only two scenarios that they are going to pay for a B12 injection, is if it is for an anemia or B12 deficiency, and hopefully you have laboratory or testing proof of that in your record. A few years ago, this was a hot topic for Medicare, and they would go back and look in documentation to see if there was any diagnostic proof of those diagnoses, and if that was not on the record, then they would deny payment. If your patients are just coming in because they get the B12 shots to improve energy and focus and concentration, that's patient responsibility, and you would need to obtain a waiver. Okay. Excluded services are our routine annual physicals, like we talked about. Those go to patient responsibility. Now, I will say that the routine annual physicals, you don't necessarily need to get a waiver, although most of the practices that we work with do, just to smooth out that conversation with the patient and let them know that they are responsible for that cost. The routine annual physicals are still non-covered, where if the work is actually for an annual wellness visit and there's separate criteria for that that is not a physical, that's a separate scenario. But a routine annual physical does not require a waiver because it is statutorily not covered. But you can obtain a waiver just to smooth out that discussion with the patients. Obviously, things like routine dental, hearing tests, eye exams, those are never covered. Those are patient responsibility. If you do nail trimming, be sure to check on the local coverage determinations for that service because they do still require the patient to have a chronic illness that's causing them to need a clinical professional to take care of their nail care. So you need to make sure that you are meeting that criteria in the RHC before billing. And we've talked about B12. If you have a patient with no diagnosis, that is patient responsibility. And in that circumstance, you would need a waiver. Anything that's experimental, obviously that's not covered really by any payer in most circumstances. And then remember that any prescription drugs, oral medications administered to the patient, those are not billable to Medicare. Shingles vaccine has been, that Zostavax has been a big one over the last several years. Some of those may be covered under the patient's pharmacy plan to include Part D, and you would file separately those services to those pharmacy plans instead of Medicare. Then we wanted to talk about immunizations. Obviously, Hep A or any of the hepatitis, those are considered just going to be a regular vaccination. If administered during the encounter, that would be paid under the encounter rate. But if performed during a nurse-only service, again, would go to cost. The thing you want to remember about tetanus is that the patient has to have medical necessity in order to bill it. Tetanus, if you have a patient that's coming for an injury or there's a diagnosis to go along with that to say we did it prophylactically because they just scraped their arm on a rusty nail, that is what Medicare will pay for. If a patient is just maybe traveling in another country and getting a prophylactic immunization because they're traveling and that's a requirement to enter the country, that is not medically necessary in CMS's eyes, and therefore that is patient responsibility.
All right, I will pull up the second polling question now. everyone would please put your vote in. A few more seconds, then I'll switch it back over to the PowerPoint. All right, back to you, Marla.
Wonderful. Well, congratulations. That was 100% accuracy. That is exactly correct, that the lab is, or the RHC is required to do the 6-wave tests, but then any other diagnostic services are an option for the RHC. They really can choose to do whatever they want to do. I know we have varied scenarios over the country. Some are very small RHCs, and they just basically have lab, and that's it. We have some larger RHCs or RHC systems that have imaging. They have PFTs, they have EKGs. Usually in most circumstances we have EKGs, and lab is pretty common in the RHC setting. So well done, well done. We're going to talk a little bit more, just drill down some additional guidance on that diagnostic test billing, because this is a split billing scenario and will most likely be the same for your state Medicaid plan. So let's talk about Medicare, and we're going to talk about independent RHC first. The technical component of your any of your diagnostic tests, so that's going to be imaging, EKG, lab, anything that's diagnostic or technical that is performed within the 4 walls of the RHC is what we're talking about. And this category has really spread over the last several years. We've got providers that are doing EMGs and more invasive diagnostic tests that may not fall to an 8 code or a 7 code, but yet are still diagnostic, and they're split between TC and professional. Those services also fall into this category, even if the provider personally performed the diagnostic test. That is potentially going to be held to these criteria versus some of the other criteria, so keep that in mind as well. Some of our services that we're seeing in the RHC are really growing exponentially, particularly if you have any specialists that are part of your RHC staff. So the technical component, an independent RHC bills those to Part B on a 1500 claim. You'll use your group or your clinic MPI, obviously, as the billing, and that will be paid under fee schedule. The professional component comes into play if your RHC providers are actually doing the interpretation. And so that's going to be either part of your charges that go with an encounter for that date of service, or if done separately on that other date of service, that's that scenario where we may have a service that may just go to cost. Particularly for state or for primary Medicare, because they don't consider that a face-to-face visit if they're just doing the interpretation that day. Remember, on your professional component, you want to go ahead and put that 26 modifier on the UBO4. Medicare really doesn't pay attention to that 26 modifier. It may be something that's just easier to track on your side, so you know that you did not send the global through by mistake, and making sure that the charge is pulling correctly for that 26 or professional component versus the global charge. Same thing with the EKG. Make sure you're sending through that 93010 without a modifier, obviously, for an EKG interpretation if that's performed. Laboratory, you're not going to have a lot of circumstances where you're going to have any pathology services then in the RHC. So you won't have any lab professional services that go through. It will just be the lab test itself that will go through. And remember that your blood draw would go on your professional claim if done during an encounter. For provider-based RHCs, the technical component done within the 4 walls of the RHC are billed by the parent hospital. So they are going to generate that UBO4 to Part A under the hospital's number, and then they are paid based on the methodology, whether it's fee schedule, cost, under the APC, whatever the rules are for that site of service. That's the reimbursement that you will receive. The professional guidelines are the same for provider-based entity. If your providers are interpreting, then those services go out on the claim form. I know we talk a lot about non-physician practitioner, nurse practitioners, PAs, and diagnostic tests. Just remember that if you are doing anything over an EKG or lab in the office, make sure that you have a physician on site. Non-physician practitioners under Medicare guidelines may not supervise a diagnostic test. So we've had some circumstances where cardiologists have been added to the RHC staff, and they do some diagnostic cardiovascular testing like echoes and treadmills in the RHC because that's where they're housed for maybe a day or two a month. The cardiologist or a physician has to be on site when those tests are being performed, and things like stress treadmills have to be personally performed by the physician or directly supervised. Non-physician practitioners under the Medicare guidelines cannot themselves supervise or be billed incident to for diagnostic testing, other than EKGs and laboratory tests, because those are in a category that don't really require the supervision limits that they do for some more invasive diagnostic testing. So just keep that in mind as well. For state Medicaid, now this is just a general recommendation or guidance. I do recommend that you do go back to each of your state Medicaid plans to verify, but in most circumstances your encounter services are going to go on a UB or a CMS 1500 depending on the state. Your encounter services, so that's going to be your professional services. That claim is going to be billed under your RHC number. And again, usually they want all of the services that are provided during that encounter to be billed on that claim to state Medicaid. And the revenue codes are going to be very similar, that 520, the 521, 524, 525, if indeed they want a UBO4. You'll use place of service 72 for RHC if they want a 1500. Most RHCs under state Medicaid are either paid under a cost-based encounter rate like Medicare or a PPS rate. Some states will pay 100% of charges. It just depends on your state Medicaid plan. That's why we try to kind of divvy up the guidelines, and we always recommend going back to the state to make sure that you understand what their guidelines are. The services that are usually paid under the visit rate for a state Medicaid plan are, of course, your face-to-face core services. They do include the clinic, the nursing facility, those swing services, skilled nursing, rest home, all those types of services are usually included. Now, I want to maybe advise on your hospital services. Usually, we have seen for the RHC side, for state Medicaid, you want to bill those hospital inpatient or outpatient services on a separate claim. Often the state Medicaid plan will have you enroll for a separate non-RHC provider number that you would submit things like your technical services, your hospital services, anything that they want to pay out of the fee schedule bucket instead of the encounter rate bucket. So you want to make sure you verify that with your state plan. Other things that will be paid under the encounter rate are, of course, your incident to services by nursing staff during the encounter, well child checks, family planning, prenatal, things like that. Nurse-only services are also handled by state Medicaid like they are with Medicare. They are not submitted on a claim form, and so they go to some type of cost calculation on the Medicaid side as well. So a couple of things just to remember, that you need to check with your state Medicaid if you don't already have that in place, whether you need a separate non-RHC provider number to bill your technical services to the state, and then make sure that you are carving out that hospital inpatient or outpatient setting if your state Medicaid plan wants them paid under fee schedule and not under the encounter rate. We've run into that with our FQHC clients with some of the state Medicaid plans where they now have moved some of those hospital services under the encounter rate methodology. So RHC to date, I have not noticed that movement as much. but just make sure that you are checking with each of your states. The non-RHC services for state Medicaid, as we talked a little bit about before, are usually the hospital, any therapy services. We didn't talk about physical therapy services for Medicare, but Medicare does not consider therapy a covered RHC service. So if you have physical therapy or any other therapy in the RHC, Medicare, you will not send a claim form. If it falls on the same day as an encounter and they're in there for some other medical service and they have a therapy visit that same day, that would be similar to your diabetic education, where that's considered an ancillary service at that point, and you can add the charge to the claim. But a solo performed therapy service is not billable to Medicare, but potentially could be to state Medicaid. Any medication that's dispensed, again, the state Medicaid will also pay that outside the encounter, as well as those technical services for some medication, especially oral medication, things like that from a pharmacy. You don't want to put that on the claim to be paid under encounter rate. Making sure that you're using your provider number or a non-RHC group provider number if your state requires that. So again, I would recommend that you go back to the state to make sure you have those things set up. I know everyone in Missouri, that's how that is to be done. They want a non-RHC number on the claim for those technical services and the hospital services so that they're paid appropriately under a fee schedule, for example. Okay, we're going to finish up today by going through the detailed billing, just to kind of loop into some of the billing information that we've talked about today. And talk about how those things, those services need to show on the claim, and this will be specific to Medicare, primary Medicare. And just to note, I know RHCs often will consider their managed care plans as part of this benefit. The managed care plans, both on the Medicare and Medicaid side, are not technically part of this benefit. This is just your traditional plans. Managed care plans will often contract and identify on their contract that site is an RHC, and therefore, some, especially provider-based clinics, will often have in their contract that they want to be paid for at least that RHC rate, like a wrap payment, for lack of a better word. But really, your reimbursement will be at least this RHC rate. Otherwise, you're paid fee schedule from those managed care plans, both Medicare and Medicaid side. So those and your commercial plans, those are all billed on $1,500, paid under fee schedule. Just wanted to make that clear. So for your traditional Medicare patients, this is going to be UDO4. Obviously, your forms have to be the most current and HIPAA compliant. Your electronic transactions, obviously, are what you're filing on. You are billing to the Medicare Part A MAC. You do want to make sure that your claims don't overlap calendar years. We just had a call with an RHC just the other day that had some services that they had put a to and from date, a date range on the claim, and it was from December to January, and obviously got a denial kicked out. Remember that for RHC claims, you really are only going to have one date of service on that claim, so you're not going to use that field for date ranges. It's going to be the date of that face-to-face encounter. The type of bill will be dependent on the scenario. So you're usually going to be using the 710. The 710 is going to be a non-covered charge. The only time you'd send that through is obviously if you have a service, maybe it is an annual physical that you know is not covered, but you need to have the ability to file to a secondary. So you need to get a denial. You could submit on a 710. 711 is the claim form that's going to be most usually used for all of your clinic or eligible encounter services. That's your admit through discharge. But remember, you don't put your different dates in there for admit to discharge. It's just the date of service. 717 type of bill if you're doing an adjustment, or a 718 type of bill if you're doing any type of cancellation, completely voiding that service claim. Remember that Medicare secondary payer guidelines must be followed in the RHC as you would any other clinic setting. Obviously, you want to have those forms completed. Most clinic settings have those filled out once a year, but it needs to be reviewed at the time of each visit. So at the point of service, we all have that where we walk in and register with the front desk. They ask us if our insurance is the same. Those questions have to be asked every time the patient comes in. So there is a specific form that should be completed for Medicare secondary payer if that is the case, because again, from an RHC perspective, if Medicare is the secondary payer, you're filing based on the primary carrier first, and a lot of these billing guidelines will not apply because the Medicare is secondary. There are some scenarios where your patients may change insurance, so you just want to make sure that these forms are completed if applicable and that they do check on that frequently. It's required, or at least recommended. Best practice is that they be reissued, re-signed, re-looked at once a year when you do all of your other privacy and HIPAA and everything else at the beginning of the year. But in the clinic setting, that's usually the best practice, and I have provided the manuals and some of the fact sheet links for you for additional information if needed. So in the RHC, obviously those of you on the call who have been in the RHC setting for many, many, many years know that now it's been several years back, we went from a very simple filing process to a very detailed filing process. Prior to, I think it was, between 2013 and 2016, they started rolling into the new guidelines, and they went from a UB04 with a revenue code with no codes and only one charge, to a UB04 with multiple revenue codes, multiple codes, and charges. And so it has been a very difficult transition for the RHC community. Fortunately now, I think most of the regional MACs now have their ducks in a row, and we have not heard of very many, if any, circumstances where there has been some hiccups in the billing. We do hear about denials. We have heard about some of the services that have gone through, particularly preventive services, and or some of the care management or the care coordination services that are still being kicked out from some of our regional MACs that just don't have their edits set up correctly. But from a pure filing and then encounter rate payment service, we have not heard across the country that the regional MACs are having as much trouble as they did back a few years ago. So effective April 1st of 2016, that's when the transition took place, and it was quite a thing. I will say it was very difficult for the entire RHC community to make these changes. It included those exempt from electronic reporting, but basically we were now required to list all of the CPT or HCPCS codes on the UB04 if performed during that encounter. There was going to be an appropriate revenue code for each line item, not only the qualified visit code like an evaluation and management service, or if it was a standalone procedure code, but also if incidental services were done on that day, such as a lab draw or an interpretation or a vaccine. There are other drug codes or revenue codes that are to be assigned on the claim form as well, but the payment remains the same. We are still under the encounter rate methodology. Now, there are a few things that fall out of this, and one is the flu and pneumonia. The flu and pneumonia vaccines, regardless when given, so that's going to be whether it's during an encounter by the nurse or during just a patient walks in and asks for it and the nurse gets it. If it is a Medicare patient, those flu and pneumonia vaccines are to be reported on a log sheet, and that log sheet is reported with your cost report at the end of the year, and Medicare reimburses you 100% of that. That is a covered preventive service. You do not assign co-insurance or deductible for those. So even if a flu shot is given during an encounter, during a medical visit, that flu or pneumonia or both, the vaccine codes and the administration codes would not be on that same claim form. You will not submit a separate claim to Part B. You don't submit a separate claim to Part A for these. It is literally put on a log sheet, and you're just paid in total at the end of the year. Hospital professional services, our guidelines for that did not change. We have to report those on the 1500, and you are paid under a fee schedule. Now, very quickly, we always have the scenario of if you are a critical access hospital on the call today, you may have a scenario where you may want to add your RHC staff to your Method 2 election if they are doing services in the outpatient setting. So Method 2 election, where you would report professional services on the hospital UB and pay that little bump in reimbursement, is not applicable to the RHC itself or any services that you're billing under the RHC encounter methodology, but they would be acceptable if your providers go over to the emergency room, for example. That's usually where we see it. It's in the emergency room and your docs come over to do rounds. If you want to, you can include them in that election because that service is paid outside that RHC benefit. And you could add them to your election, and then when they're in the ED, those services are billed under your outpatient hospital UB and paid that bump in reimbursement. So just wanted to toss that in for any critical access hospitals in the call. Telehealth, Remember that RHCs at this point in time are still not eligible under the Medicare program to bill a distance site professional service. So for example, another entity could not call into your RHC. I know this happens quite frequently for behavioral health when another entity may call into yours for behavioral health therapy or services. But right now Medicare does not allow a rural health clinic to be a distant site, but they do let you be the originating site, which is where the patient is when you call out to another organization for other professional services. So that would be under 780 revenue code. That would go on the UB04. It is paid under fee schedule, but it does go on the UB04. Okay. These are some of the exceptions to our detailed billing. So for detailed billing, they kind of drilled down to a qualifying visit. And a qualifying visit is defined, obviously, our face-to-face visits as a medically necessary medical or mental health visit. It could also be your preventive visits that are qualified under Medicare, like your Welcome to Medicare Physical or Well Woman, GO 101. Transitional care management, that's also a criteria because that does require a face-to-face visit with the provider, as well as advanced care planning. That requires a face-to-face visit, and so those are eligible. You can also report those incident to services done during the encounter, and those charges are also listed on the claim form if they are done as part of that encounter. Every service that is provided is listed on a separate line on the UB04. Each line will be paid or be tied to a qualifying revenue code, and those are going to be your 520, 52X revenue code. So it might be a 521 for office, might be a 524 for a nursing home or nursing facility, might be 900 for mental health therapy visits. Those are qualifying service lines. That line item will need to be appended with modifier CG, which most of you on the call today are most likely very familiar with. That CG modifier tells Medicare, hey, this is our face-to-face visit with a core provider, and we need to be paid our encounter rate. The incident to services are also listed on the encounter form or on the UB04. So if you have a procedure note, they may have done an office visit and they need a laceration repair, and they might have had a some type of antibiotic or other type of medication. All of those service codes and charges are listed on the UB04. Now, the revenue codes that I have listed here are the ones that you may not report. Because those are tied specifically to a true hospital inpatient or outpatient setting and therefore cannot be reported by the RHC. But these are some of your common ones you're going to see. Obviously, the usual and customary 5 revenue codes for your visit in the clinic, a visit to a patient's home, a visit by your provider to a Part A SNF or a skilled nursing facility setting, 525 to a patient who is in a non-Part A covered stay or something like a rest home or assisted living scenario. 527 if you are in a shortage area, and that is a home health shortage area, not a medically underserved shortage area. If you meet that criteria, there are also guidelines for visiting nurses. We have very few clinics that we work with across the country anymore that are within a home health shortage area because those are so populated now. 900 would be if you have a mental health provider there who's doing therapy. Any of their initial diagnostic services would be under a medical 521 revenue code, but a therapy service would be under 900. If you are an originating site and you have the patient there for telehealth services, that's a 780. And then the other 3 are ones we see the most frequently. 771 would be for vaccine administration administered during an encounter. 636 would be for any of your J codes, and 300 would be for your blood draw. Any procedures that you would do as standalone, like they have a lesion removal, they take off, several skin tags and tell them to come back in a week or 2 to get the rest of the skin tags taken off. In that scenario, you would not bill an E&M service because they've already been evaluated and the treatment plan established. You would bill only the lesion removal or the skin tag removal. And that date of service, you would submit the appropriate procedural CPT codes with 521 and that modifier CG, and that will prompt your payment. Now, the rolling of charges, this is one thing that made the transition very difficult because you still have the rolling methodology where you're bundling all of your charges to that qualifying visit line, even though you list each one individually. And so on the UB04, you are going to still have that qualifying visit line. And it may not be the first line on the UB. It's going to automatically sort by revenue code. It doesn't have to be the top line of the UB04, but it has to be tied to that qualifying visit service code, which will be either evaluation and management, or on a standalone procedure day, it's going to be your CPT procedure code. But all of the other charges that you may list on that claim the same day will roll to that qualifying visit line, so you'll have your total charges. That total charge is what you assess your coinsurance against, and that's what Medicare assesses the coinsurance to. So you have to have some dollar amount in each of those line items, a penny or over. Whatever your fee schedule charge will be pulled to your claim form. Now, when you get your remittance advice back, obviously Medicare tells you these are additional lines. We recognize them, but we've already paid you your encounter rate, similar to a commercial insurance that would tell you your additional services have been bundled or paid content to that E&M service. Same premise. You're still being paid against that total charge line, and you are being paid your encounter rate. Okay. There are going to be some exceptions where you don't want to roll those charges into that total line. That would be if you have multiple services that day, which includes one of the Medicare covered services. You want to make sure that those codes would be excluded or subtracted from that total charge line and not included in that line item to calculate coinsurance against. Okay. The modifier CG can go on the preventive service line and should be there just so appropriate payment is made, but your service may not necessarily be rolled into, nor would it be assigned that coinsurance regardless whether it's a service that's performed with something else that day or whether it's the only service provided that day. No incurrence or deductible for those covered preventive services. The claim lines, again, we had a lot of questions when this first started about the order, and we want that on the first line, but it doesn't come out that way. Again, it's going to sort by the revenue code on those UB04s. That's just a normal part of that electronic transaction. And so there's nothing you can do about that. You just need to make sure that your systems are set up to append that CG modifier on the appropriate line with the appropriate CPT code. Okay. Now, at the bottom of the UB04, of course, we've got the total of the UB04 claim itself, and this also caused some angst when the transition took place, and Medicare did have to do work on their side to make sure they were not paying against that bottom line item, that 0001 line item. Excuse me. That does show an inflated charge because the UB transaction will automatically re-add everything on that UB. So we'll take the line item that you've rolled your total charges to and then add everything in again. So just really don't pay attention to that. Medicare does not process against that, and it's our burden on the billing side and the reimbursement side to make sure you're posting charges appropriately, not against that inflated charge, but against the true charges. Modifier CG, this is the golden modifier that prompts your payment. And it does have to be set up so it maps or appends to your qualifying service code, whether that's going to be an E&M code for that data service or whether the patient comes back in for just a procedure, so it goes on that procedural CPT code or that surgical CPT code. They may be in for a preventive visit, and it's appended to that. You just want to make sure that your system is set up appropriately. Now, Medicare has said that they don't expect or need to see that CG on that IPPE service, that Welcome to Medicare service. If it's on there, they just ignore it and pay appropriately, but it is not required. So you could set up that edit with that IPPE to not kick to that code. The CG modifier also prompts Medicare to appropriately calculate that coinsurance from that total charge line. And then if you have a circumstance where you have a medical and a mental health service on the same claim, that they're calculated appropriately, and that if there is a covered preventive service, that they don't calculate the coinsurance. So that's all set up in Medicare's edit, so you just want to make sure you have appended the modifiers appropriately. Here's just a few examples that we'll walk through just to give you visuals. I'm sure most of you on the call today are very familiar with this now, but if there are any fairly new RHCs, you may still be a little confused about the methodology. Hopefully you're working with vendors that are well-versed in RHC to help you set up your systems. But basically you'll have a line item for your office visit or your qualified visit code, which in this circumstance is a 99212. You would modify it with the CG modifier. In this scenario, Medicare provided the E&M service was charged at $150. We also had a radiology technical or professional read, we assume, and the J code. In this example, I find it interesting that they did not include the drug administration charge. But having said that, when you the line item that is boxed in red is really your total qualified line item. So the charges for the radiology and the drug are added to the evaluation and management service of $150 to reach the total charges of $350. So that's just an example of how that rolling occurs. And you also want to notice that there are the associated revenue codes for those distinct ancillary services, the 636 for the drug and the 320 if you were doing any type of radiology or radiology interp for that professional service. Another example is just your medical service on one date of service. You have revenue code 521, the evaluation and management code with CG modifier appended, your charge, and then you would be paid the encounter rate. You will also calculate, Medicare will calculate the coinsurance and deductible. If you have a medical and a preventive service, in this example, we have a well woman exam or someone who's received the covered breast and pelvic exam. So you have a medical 99213. That would go through as your covered or your qualified visit with the CG modifier and the charge. You have a line item under 521 for the G0101, which is that breast and pelvic exam. You would have also had a code for Q0091 if they also took Pap smear for that date. And then they ordered lab, and there was a lab draw. So the 300 revenue code and the 36415 is listed. The charges for $38 and $3. The charge actually in this scenario for $3 is the only thing that rolls to that revenue code for the qualified visit. Our qualified visit is $75 or $3 for our 99213. We've rolled that $3. The $38 for the G01 is not rolled because that is a covered preventive service, so no coinsurance, no deductible, but you are paid for the entire service under the encounter rate. A preventive service, this is another example of just a solo visit for a well woman exam. This is the coding for the breast and pelvic exam portion of that, the G0101. In this circumstance, since it's the only service, you would append that with the CG and the paid under the encounter rate. No coinsurance or deductible would be assigned because of the HCPCS code. That's what drives that. Now, if your provider, and in these circumstances, they would also do that head-to-toe preventive, so you'd really have a routine annual physical as well work that was done, you would bill the remaining charges for that 99 CPT code for that routine annual physical. To exclude, this breast and pelvic portion, that charge would go to the patient. It would not necessarily be filed to Medicare unless you needed a denial, and then you would send that on a separate claim form, another type of bill. Mental health services, if you have those in your RHC, this is just an example of a medication management service and then therapy. And those also roll just the same as you would for medical services. This med management code actually is the service code if you have a clinical psychologist on staff and they are actually eligible to prescribe. They're the only ones really that can do medication management, but we wanted to provide you with that example. If you have multiple medical services, our example is a medical evaluation and management service that they perform to evaluate the patient and then determine that they need a laceration repair. That laceration repair is added to the UB04, and that charge for $100 rolled into the charge with the E&M service. CG modifier in this scenario is only put on the office visit code for the E&M. You won't also tie the CG modifier to the procedure code, so that gets a little tricky if those procedures would often be performed by themselves, and then in that circumstance you would need to append it if that was the only thing that went out on the claim. But in this circumstance, you would just roll the charges and be paid under encounter rate. Here's our incident 2 services. The nurse may come in during that office visit and do a blood draw, and then also give a Hep B vaccination. So you have your office visit service code. That's your qualified visit line with the CG modifier. That's going to reflect your total charges, which will include the charge for the blood draw, the charge for the Hep B vaccine, and the charge for the Medicare administration of Hep B, which they do have those specific G codes for that, flu, and pneumonia. All of that would be paid under the encounter rate. You would not have coinsurance or deductible applied to the remaining of these services. They don't assign coinsurance for blood draws, and they don't assign coinsurance for well, basically, this just means they're not assigning separate coinsurance for these 3 additional items, only on this total service line. Remember, we do have our exceptions, and we want to finish up with that, where we do have those exceptions. Remember, if the patient was there in the morning and then left and had an injury and came back, a completely unscheduled, not known circumstance on that day of service, those are qualifying visits to be paid twice. If you have a medical and a mental or behavioral health visit on the same day, and then if you have a welcome to Medicare physical and any other service that same day, they are eligible for 2 encounter rates. So this is a scenario of how those would be billed. And this is where we have new modifiers that will need to be used. And Medicare has assigned us with either a 59 or a 25 modifier that will tell them we need payment for this exception. You want to remember, and those who are coders on the line will know that a 25 modifier in the regular Part D world means that we just had an E&M and then some other service that same day. And the definition of 25 for us on the RHC side is not going to be the same for primary Medicare. For primary Medicare, it means that we have a qualifying visit and we have a second qualifying visit on that same date of service. So you can either set up your system with one or the other of those modifiers. I would recommend pick one and not go back and forth. Just pick one to use consistently. So we have an office visit, and then we also have a therapy service, as well as a covered annual wellness visit, which would, or an IPPE, which would mean you would 59 modifier the second 2 lines, which would tell Medicare we need payment for these additional line items, in addition to the office visit.
All right, and now I'll pull up the last polling question. If everyone could please put their votes in. A few more seconds and I'll switch back to the slides. All right, back to you, Marla.
Okay. Very good. That was kind of a trick question. So you all did very well. Really, CG modifier, everyone was correct. That is going to be the primary modifier you're going to see on your claims to prompt a payment for that encounter. That 25 or 59 would only be appropriate if you have an exception that's met. So that would prompt the encounter rate, but only if an exception is met. So everyone did very well. Congratulations. And that completes the formal slides for this presentation, for this session. And so, Senator, we have a couple of time for questions. And then tomorrow, after our session tomorrow, we will have more time for questions as well. So hang on to them if we don't answer them today. Senator, I'll toss it back to you.
Yep, and just a reminder, everyone, to unmute your line, press *2. or the chat box is also available. So
Okay.
they're still coming back with a question, Brandy.
Okay, Brandy had a question. Oh, doing Medicaid primary and RHC, other services performed outside of visits payable? No, if you're talking about nurse services for state or primary Medicaid that you would provide outside of that face-to-face encounter, that's going to be the same rules as with primary Medicare. So let's say it's a well child check, they come in for their EPSDT with the provider, they give the first round of vaccines, but they tell them to come back in a couple of days or next week to get the rest of their vaccines, and they only see the nurse. You cannot generate a claim to Medicaid for that. That's going to go to their cost calculation or their information they report to Medicaid, but you will not submit a bill and get paid for those. The other scenario with Medicaid you have to pay attention to is whether you are part of a Vaccine for Children program, and that's free across the board. So not only do you not charge the patient or the state for the vaccine, you don't charge the administration back to the state or the patient. Totally free. You're welcome, Brandy. Thank you for the question. Anything else that we can't answer quickly today? Looks like we're right up at 11, some of that. Oh.
Yep, looks like we're right on there. Well, we will have the second part of the training tomorrow from 9 to 11 Central Time as well. So if you have any other questions, we can go over those tomorrow as well. We want to thank you guys all for coming. Thank you, Marla, so much for speaking today. We appreciate you all. We hope you guys come for tomorrow's training as well. Have a great rest of your day. Thank you.